Oh, good. We have full panel. I want us to take a moment, just pause for a moment, and notice what your response is to the film. What shows up for you? Come face this way, you guys. We're up here, up here, up here. I'm Lynn Fritz, your moderator. I'm Swedish and Native American community, and oftentimes in at least my Swedish family, substance use is a real issue, and lots of addiction, lots of deaths. So this kind of is close to home. But notice what you're feeling when you see this film, what comes up for you. And I want to introduce our panelists. Right over here. This is Raven Hoops, Harm Reduction Specialist, Complex Care Coordinator at Hill Country Clinic and Wellness Center in Reading. They've been working with perhaps our most famous person on the panel. They've been working with harm reduction and disease prevention since 1997. From Youth Street outreach worker to executive director, she has dedicated her entire adulthood to harm reduction work. Her start in this work began when she was 17 years old with the Raven Project in Eureka, California. At which time, unsheltered, substance using, and then recently returned to rural Shasta County, taking steps to elevate harm reduction. And if you were to say what you attribute your survival to, what would you say?
Philosophies, practices, and the practitioners of harm reduction.
Yes. So next we have, yes, I'm going to find the right paper here. Susie Foster, family nurse practitioner with Hill Country Clinic and Wellness Center since 2011 and has been the chief medical officer since 2016. She's played an integral role in implementing and sustaining multiple complex care programs to wrap additional case management and clinician support around vulnerable patients for our community. The most robust of these programs is the Medications for Addiction Treatment Program. Here, patients with substance use disorders are treated with a variety of medications customized to their situation and needs. That's Susie. And Dr. Kyle Patton, the street medicine doctor and the medical director for the HOPE program of Shasta Community Health Center in Reading, our famous HOPE van. He's also completed a supplemental street medicine fellowship where he learned full scope primary care on the street to help people experiencing being unsheltered or homeless. His diverse skill set and strong beliefs to meet people where they are at helps him to be viewed as a resource, and especially so an advocate by the patients on the street. He believes in strongly in operating a harm reduction client-focused program, Shasta Community Health Center. And Jill Phillips, yes? Jill Phillips has 25 years of experience helping rural communities, raise your hand, working together to address local challenges. In 2021, began work at Shasta County to form the Shasta Substance Use Coalition. Comprised of 40 participants or more, the coalition is working to reduce the harms associated with substance use in Shasta County by aligning the work of those involved with prevention, harm reduction, treatment, recovery, and enforcement. So one of the things I want to do is ask Raven to make a statement, define, in case there's anybody here, what is harm reduction, and then I'm going to go to Jill and ask her to look at an overview of Shasta County, so paints a picture of what's happening here with sharing some statistics.
Sure. Harm reduction is it's a way to mitigate the harms that are associated to substance use and other risk taking. Harm reduction is designed to meet people where they're at and to work with them on the things that they identify. It's about restoring autonomy and self-efficacy with people, and it comes without judgment. It's about destigmatizing the system and providing the tools to people so that they can have more positive outcomes and be safer in whatever it is that they are doing that's causing harm. So that is everything from the way that we treat people, the level of compassion that we bring for people, all the way to providing the services like you saw on this film, and into the political and social movement sector as well, to try to remove some of the destructive ways that we have dealt with and push people into the darkness, if you will. So really, it's about people first. It's about really looking at behaviors and not judging individuals, and then giving space for people to determine what's best for them.
Thank you. So Jill, can you give us a broad stroke of what the situation is in Shasta County? And I want to also, before Jill shares with us, these tablets are for you to put a question. If you want to ask any of the panelists a question, or the entire panel, write it down, and who's going to pick them up? Julie? Rob will. So you could just raise your hand and hold it up, and he'll come get those from you. Go ahead, Jill. Thank you.
Yes. So the Shasta Substance Use Coalition, the Shasta Substance Use Coalition was formed. Can you hear me now? No. Okay. So, as was mentioned, the Shasta Substance Use Coalition was formed in mid-2021. And the idea is to really look at our data here and understand what was happening. We knew there have been overdoses, but we knew that they were escalating. And what we discovered is that from 2020 through 2021, the EMS responses to overdoses in our county increased 125%. So from 125 to 281. And then in 2022, they increased further about another 11% to 312. And we know that the age group of 25 to 34 have the highest number of opioid overdose incidents. And also between 2020 and 21, the overdose deaths increased by 500% in our county.
So I would also like to ask each one of you, when you saw this film, what do you think was important about it? Who wants to go first? Susie.
I think that one of the big takeaways that I hope that everybody is able to take is that these people are humans, right? They all have stories. The guy at the beginning said, the difference between you and me is that I made one bad decision. We all make bad decisions, right? That's part of being human. And so it's part of that realization is part of breaking that stigma. The opposite, we say, like the opposite of addiction is not sobriety. The opposite of addiction is connection. And so sites like this, relationships like Dr. Patton has on with the Hope Van into Street Medicine, relationships like we try to develop at Hill Country with our patients, it's not even so much about that sobriety at that one moment in time. It's about, let's give this a try. If this doesn't work, I hope that and you don't come back, I hope that in 4 months you do come back so that we can work on it then.
Don't you think, though, that making a connection really supports people in taking the steps for reducing harm to consider treatment?
I do, when they're ready. right?
When they're ready.
When they're ready. So the thing I would add to Raven's description of harm reduction is harm reduction isn't it's not putting my agenda in front of the patient, right? It's the patient's agenda. And one of the first things I ask patients is, do you want to stop using? I mean, we have patients who come and see us who want to stop their heroin or their fentanyl, but don't want to stop using meth. And that's their choice.
Any thoughts, Dr. Kyle?
Yeah, it's I watched this not only tonight but last weekend. I watched it for the first time, and it was kind of to wax personal just for a second. It was kind of interesting because as I'm watching this, the thing that my dad used to say to me when I was a kid kept kind of like running through my head. So my dad's a retired Navy commander. I grew up a Navy kid, Southern California, and when I'd go out with my brothers, my dad would always say, keep your head on a swivel, your eye on your shipmate, let us all press on. And, obviously he was like telling us not to do something stupid, right? Like don't get yourself hurt when you're out there with your brothers. But it really, that quote, that thing my dad used to say, and by the way, I say that now to my kids and my coworkers, which was a terrible realization. See that I'm now saying what my dad said to me. But I think it really speaks to our work, right? Like that idea of keeping your head on a swivel, not so much from a safety standpoint, but just being alert to the crisis that's in front of us. A lot of those harm reduction principles are based in trying to understand where your patient is coming from and a lot of the barriers that they face. And so, I think that's important. And then keeping your eye on your shipmate, right? Like these are people in our community. And these are people that are suffering. And so, I think we get a lot of solidarity out of the work that we do, not just with each other and doing this work, and also, working directly with our patients. And so, yeah, that was kind of, what I was thinking as I was watching the video.
How about you, Jill?
Let's try this. Does this work now? No. When I saw that, this film just did bring to me all of the connections that are so important, and all the individuals in this community who work with those that need those connections. And it really is about relationships and building that trust. And boy, it's hard work though, isn't it? It's a lot of hard work.
What about a harm reduction site in California?
The harm reduction site in California? Well, in California, there is a lot of harm reduction. There are no safe injection sites that I know about, and I don't believe that that the state allows it at this point. Maybe you may have more information than that, but that's where we are. The safe injection is not what we do in California at this point, but there are a lot of harm reduction strategies that are very helpful in this.
Yeah, sure. So for me, this film perhaps lands in a really personal place. We don't have approved overdose prevention sites in the state of California. Last year, the governor opted not to pass SB 57, which would have allowed the first pilot in San Francisco to happen. We do have them in New York, is the place in the U.S. that we have them going on right now. I have not spent my entire life, adult life, in an overdose prevention site because we don't have those, but I've spent my entire adult life in essentially that same office with those same people. And when I say those people, I just want to, what's important about this film is that we stop saying these people. What's important about this film is that we stop saying that what we thought was working is working. What's important about this film is to have those of you who don't have the life experience, to honor that people who have the life experience are the people who have been keeping each other out of harm's way to the best of our ability for decades. This work has been going on for a very long time. Harm reduction is not new. Overdose prevention sites are not new. Even the idea of safe supply is not new. It might be new in Reading, but it's not new. So what I think is the direction of the film, and particularly in meeting with the film director, is that we need to shift the narrative so that we remove the stigma, so that we stop seeing each other as separate from one another, because we're not, and we're all just one incident, not a bad choice, but we're all one incident away from being in any one or any near this situation. And I encourage you to think the same thing when you look at your unhoused community and how you depict them when you walk by. And if we could change that narrative by seeing things like this that work and create that connection and create that community, I have had the most enjoyable times in my life in these offices, at these dance parties, to this really, unfortunately, not great karaoke, right? Like, so, and what I'm telling you is that I'm here because of this kind of work. So when you're wondering in Shasta County or wherever in the world, why does this keep going on? Look to people like me, look to people in the harm reduction world, look to the people who are sitting on the side of the street that as you pass by, you cast your judgment, because substance use is not a matter of, and I know that that's one of Colin's main focuses with this film, is please look past just the one road.
Not only have they been around for a long time, they're also well validated, right? So, we don't do randomized controlled trials in the setting of overdose, right? That would be very unethical. But there's a lot of observational studies that have shown that OPCs have a clear community-wide benefit. Not only do they reduce the mortality risk from overdose, but they also reduce all-cause mortality risk, right? And observed, so the supervised injection site that we saw in the video. And I just blinked on the acronym.
Overdose prevention sites.
Prevention.
Yeah.
Yeah. Clinic.
There's a million variations, but.
So I mean, this is like well established, right? Like the studies show that these interventions do have significant benefit. That's important too, right? So when you talk about, I work not only with a lot of patients that use substances, but also patients experiencing homelessness, and their mortality benefit or their mortality risk compared to the general population, like it's 9 to 10 times greater. And that's not only from overdose, but that's from a wide variation of things. Mm-hmm. And so, this video is really highlighting like a multitude of crises and various barriers to care that are having. What saying is that we need to do things differently, because what we're doing right now with siloed healthcare and our kind of traditional models, like it ain't working.
Co-occurring disorders, dual diagnosis, mental health and substance use. Can you speak to that some? Or maybe your own organization, how you work with it?
Yeah, so I kind of laugh because we have providers and therapists at Hill Country who say, oh, I don't treat substance use disorder, patients with substance use disorder. And really, it's that's just a story that they tell themselves, because all of us are addicted to something, like, right? All of us, like Raven said, have a sugar addiction. All of us have, there's something. So at Hill Country, we try really hard to just wrap as many services as we can around a patient, and we just treat them with whatever they need, right? Again, it's that meeting the patient where they are. It's addressing their agenda, not our agenda. So we have behavioral health consultants. We have behavioral health, we have behavioral health care coordinators. We have specialty mental health. All of those services are able to address patients' needs from different facets. So if they need substance use treatment, we treat that as a primary care condition. So most of our providers are able to prescribe Suboxone. Now everybody's able to prescribe Suboxone, but before this year, you had to have a special license to do that.
And why is that prescribed?
So Suboxone in particular is prescribed to treat opioid use disorder. It's a combination of naloxone and buprenorphine. But I would say the same thing about
What it does.
I mean, I don't want to speak for the county.
Yeah.
You know what I can. North State, we lack a whole lot of behavioral health resources, resources that we desperately need. At Shasta Community, much like Hill Country, we don't have the luxury of saying we don't treat dual diagnosis. Like, we have to do that because of the patients that we serve. And so we try to be cognizant that we're offering, full scope care. That's treating substance use disorder, that's treating mental health conditions, and doing it in a way that's accessible, right? So, I mean, that's always the issue. We deliver healthcare in a brick and mortar way, right? Where our patients have to come in off the street, leave their stuff at their camp. They have to check in at centralized check-in. They have to sit in the waiting room. At our clinic, our main site, they have to check in at their department, wait for their appointment, go to the pharmacy. They don't have an ID. There's a lot of barriers that we just kind of take for granted, right? And so, it's not just about providing kind of full scope care, but it's also like being cognizant of the ways in which we're creating an accessible delivery model.
I have something to add. In Shasta County, there's been a lot of work done to integrate care. So, for example, there is a committee called the Integrated Care Committee, and it's social services, behavioral health, substance use, providers, housing providers, respite care, the whole gamut, all get together once a month and in between. And we work to develop these relationships across sectors so that we can have good systems, not just within the organizations, but between the organizations, so that no matter what a person needs.
So that is just one example of if we could have a patient see Dr. Patton and see a therapist in one day, that's one less time they have to leave their camp. That's one less time they have to go through that very uncomfortable experience of walking into a place that they've quite frankly had quite a bit of trauma. There's a lot of medical trauma in the population.
Yes. Raven?
Yeah, so I'm commonly the unique voice in the conversation around this stuff. But when I'm asked in a venue like right now, and this film, what are we doing to treat people? It still brings me back to the core of who I am and where I come from in harm reduction to say, actually, back up. You're talking about treatment. You're talking about making decisions for people they haven't made for themselves yet. What's missing is, yes, we're missing enough mental health support. We're missing enough, doctors can't, like Susie said, you can't see the doctor and the psych on the same day, et cetera, et cetera, et cetera. I'm going to tell you right now that it doesn't matter if we fill Shasta County, every empty building in Shasta County, with a service provider. You will still miss 90% of the people that need those services. So the distance that it takes for somebody to get to the point where they have to use an OPS center, it takes an equal, if not more, distance to find your way away from that. And for some people, the reality is that they're not going to find their way away from that. They may not want to. It may not be the highest priority in their life. They may not think that it's possible to this world to change this narrative, to change all the things that y'all are concerned about, is for us to look at each other and say, I see you, right? And say, what do you think? If you're in this room right now and you represent somebody who's walking into this OPS, then that's who needs to wear the microphone, right? Like treatment is not the only thing. It's not the only thing. And it's actually the last thing that we get to as people who use substances, right? There's everything before and in between that. And we will not solve by just adding the treatment, by just adding the service. We'll make it easier on us. If Patton can call from the field and somebody can just get in, cool. We're going to make it easier on us. But we're still only going to be able to reach so many people. We need real shift in our social and political mind about why we're in this situation, about why people are not making it to care, about why people feel like they don't count anymore. So why would it be worth it for me to try for the 17th time when I'm still going to wake up tomorrow on the cold street, right? So treatment is good. And, treating co-occurring is like our most challenging situation because of the lack of services and all of those things. But it's a unique situation like anything. That's the thing, is we keep focusing on these blanketed, this is how we're going to resolve it. If we just had this is one thing. And I do want to clarify for people, there's back in the day, so I started in harm reduction in the 90s. At that time, my very first educational session with a group of nurses was literally underground. And every nurse that left that conversation, except for one, was like, dear God, no way, right? So it has been pitted against each other. People think that harm reduction is separate or different from treatment, from abstaining. But harm reduction is not a separate thing from any of these things, from MAT treatment or any of those things. Harm reduction is a continuum that recognizes that drug use is on a continuum. And so what it says is we can work with people all the way from creating a safer environment, coming into one of these facilities and avoiding death, to handing someone sterile equipment so that they don't end up with a chronic, life-threatening HIV, Hep C, or otherwise illness. And so there really is no, right? We're starting to eliminate the things that stop people from being able to have success. And all the way to abstinence. We do celebrate that, right? But what we're saying is that maybe somebody doesn't have to be abstinent from everything for their life to not be chaotic, right? And sometimes drugs are giving us more than they're taking away. I don't know how many people are brave in this room to raise their hand and say, I take drugs every day. But I guarantee you a big majority of you take drugs every day. And I don't care if your pharmacist works at CVS or on the street corner. And the only thing that separates those drugs has to do with a political, social conversation.
Mm-hmm. Question here is, are there other similar narrative pieces that you know about that about overdose and or fentanyl you would recommend to those interested on the subject?
I mean, those are the sort of the champions at the national level that keep track of all of us who do harm reduction work. Look at the Drug Policy Alliance. The Drug Policy Alliance puts out a lot of really great resources and connections to films and trainings, etc. It's out there. You just have to do a little bit of research. You can just type into your little box harm reduction and it'll give you a whole world that you didn't know was out there. Or maybe you did. Some of you out there know.
Dr.
There's a
Patton.
really good book by Dr. Gabor Mate.
Yes.
Called In the Realm of Hungry Goats. He's actually a doctor that did a lot of work in this exact neighborhood in Vancouver. And so he goes into not only some of the treatment aspects, but also like a lot of kind of the harm reduction principles that he and some of these other people.
Yeah, he's recognized in the field of psychology as one of the leading experts. He's a very thoughtful person. One of the questions that came in is tool to be used to detect fentanyl in drugs.
So we have test strips that can be used to see if there's fentanyl in your drugs. They're not a perfect tool. They can present some discrepancies, but they're a tool. And with good enough training, people can determine most of the time if there's fentanyl in a drug that they're not expecting to have fentanyl in. all of that to say, I would say that several people are consciously switching to fentanyl, in which case they wouldn't necessarily be testing for it if that's what they're actually trying to get. So I think they're still relevant.
It was more applicable a couple of years ago.
Yeah.
When we were like first starting to see people patients making that switch from heroin to fentanyl.
Yeah.
Or were worried that it was maybe laced in the product locally. Now most of my patients are using straight fentanyl. But there's ways that you can use those fentanyl test strips, mainly with like a lot of our methamphetamine users, because they do have, fairly significant concerns with staph laced in their products. But there's, you might have seen in the...
We speak on the tools, but part of the work of harm reduction is what's the most important part of the conversation. Other more important messages, 7 to 15 other messages we need to be talking about that are even more important than the test strips, although still a tool.
What is medication-assisted treatment?
So medication-assisted treatment is the practice of using pharmaceutical drugs to treat a variety of substance use disorders. So we use Vivitrol or naltrexone for alcohol use disorder. We use buprenorphine, different combinations of buprenorphine for opioid use disorder. There really aren't good medications for stimulant use disorder, although there are some kind of that are maybe being tried and starting to emerge a little bit.
And is that standard for family practitioners, or is it more in the clinical setting like Hill Country?
I think that
Sure, you'll be seeing more of it because we have just eliminated the extra loophole that physicians have to go through to be able to prescribe the medication. So once we catch up the legal jarble and paperwork to that, I think we'll have more providers coming on board.
I mean, I think so. To add on to that, so not only have they changed the law, all practitioners can prescribe Suboxone. In the future, they're going to have new practitioners that are applying for a new CPA license.
So we did a survey in 2021. There were somewhere in the neighborhood of 1,300 to 1,500 individuals receiving medication for opioid use disorder and have MAT programs, and then a couple that are virtual. So there's 8 that are right in town or up in Bernie, and that it's
in private practice,
in their clinics, in general clinics. Yeah. So there's a Mercy Bridge program that was mentioned, and so an individual can actually get started on Suboxone there if they're ready, and by methadone and Suboxone. And then Churn Creek Healthcare, Ready Rancheria program, Shasta Community, Pitt River Health in Bernie, Mountain Valley Health Centers in several rural locations, and then Bright Heart Health and Recover provide 100% virtual programs.
Excellent. When you think of
when you don't, your teen pregnancy rate skyrockets, right? So, but that doesn't mean that when you hand a kid a condom that they're going to run out, and it's not like they're like, yes, I'm ready because I got the condom, If I walk around the room and hand you all a syringe, are you going to go home tonight and inject drugs? Are you going to go figure out where to cop fentanyl and go home and inject drugs? Probably not, right? We know that in other countries and sometimes in our country, in situations where people don't have access, that people are sticking needles in their arm that belong going into elephants, right? Because that's the only thing that they can get to. That causes an extreme amount of damage on that individual, right? And I mean, we're talking about information that goes back to 70s, right, and 80s, and the Center for Disease Control saying, look, we've got this explosion of HIV amongst people who inject drugs, and there's one way to stop that. Give them a sterile syringe every time they stick a needle in their arm, period, right? Nobody wanted to do that at that time, so the people who did it were the people who were doing the drugs, right? Because no one else wanted to help us. We had to help each other. in order to survive, right? So, and just because those things happened didn't mean that your kids went running out into the street going, yes, it's okay for us to do drugs and inject drugs. It's not. And we still get a whole bunch of judgment from people who are doing other kinds of drugs, right? That exists. So it's not, this is about safety. It's about harm. It's about risk. It's about addressing those risks and trying to help our fellow people, ourselves, to be able to survive and live as positive and wholesome lives as we can. And without the tools in order to do that, we suffer further beyond that. But no, the idea of enabling, the idea of all of that stuff is so Reagan.
Yes.
So I don't know how to follow up that comment. That was awesome. Right?
I know.
That just came out.
It was good. No,
I'm
it's
trying
good.
not to.
So, I think so. I'm thinking of the times where I've actually used Narcan on a patient out on the street, right? So I've given Narcan in the hospital when I've worked in the ER, but when I've been out on the street, like providing care, and I'm out on the street out at the camps fairly regularly, like multiple times during the week, in areas where people are actively using opioids. And I've given Narcan once in my career, right? And that was a fairly low risk situation where the patient had already passed, and around us that are at risk to be able to respond to what we're seeing around us. And so I think that when we talk about harm reduction, I think that's what we're trying to do. I don't think we're trying to enable, we're trying to empower people to be able to respond to what's going on around them in their current situation.
Yeah.
And so, I think the Narcan needs to come out of our hands as healthcare workers, and we need to give it to the people that are going to be there, right? I'm not there at 1 a.m. to be able to respond.
Yeah.
So the patients need to feel that empowerment to be able to do that.
And I think we keep talking too, we do put a lot of emphasis on, and probably because we're out in the street, we put a lot of emphasis on folks who are unhoused, but part of this, my whole narrative changing spiel and this is also to say that not everybody is on the street, right? Like it's just that's what you see, because you can't see behind my walls at my house, right? So it's important for us to also recognize that there is there's a world of this going on that you don't see too. And it's important that when you're driving again down the street, that you don't separate those two. They're one and the same. If somebody has 4 walls or they don't have 4 walls, the fact of the matter is that they're at risk of harm because of the substance use and the things that go along with it. So again, yes, get the tools into the hands of the people. And some of those people are unhoused, and some of those people are living next door to you.
In your clinic setting, Susie, is there treatment available like the no harm where people can come in and do needle exchange, or is it only through the county?
There is a county program, for sure. The county program, you probably can actually speak to it better, but my understanding is it's a 1-for-1 syringe exchange. So you have to bring 10 syringes in order to get 10 syringes back. We have a physician-led syringe exchange program at Hill Country, where a patient actually has to see a physician in order to get the safe supplies. I will be honest that they actually spend more time with the case managers and the SUD counselors than they do with us. They don't need me. They don't need Dr. Patton, really. They need someone to build that relationship with and to help them with the resources.
Limited syringe service program going for roughly maybe 15 years now, 10, 12, somewhere around there. And we don't want to lose that, and whatever we can get is good. But there are some things that are archaic about it as far as it being a 1-for-1 program, as far as requiring IDs, and also it doesn't provide all of the equipment that avoids things like infectious diseases. So we are missing it a little bit. And then as Susie spoke to at Hill Country, we do have a physician-led program, but that limits it to only our patient population. And so that's good. Again, it's another thing, but it's certainly not reaching the number of people who we know need that service. So in effect, I mean, technically, a person could apply to the state of California and say, I'm going to open a harm reduction based or in-service program in Shasta County. And the state of California will say, yes, absolutely. They'll put their stamp on that. They'll notify the county. And then the county has the decision whether or not they want to push back or fight against that being in their community. But again, this is something that that's a service that has been around and suggested from the Center for Disease Control for decades as the way that we minimize harms for people who inject drugs. And again, injecting drugs is just one way to administer drugs into your body. There are other ways that produce other harms as well. So we have to also talk about those, and we have to talk about what services are needed for those. And since whoever brought up in-service programs, and that's where I come from, I just want to mention to you that if your mindset is that people need to go to recovery, people who participate in harm reduction programs are 5 times more likely to enter into recovery programs. So if that's your lot in life, is to make sure everybody who does drugs gets off of them and goes into recovery, guess what? You actually support harm reduction work, right? And it saves medical and other facilities quite a bit of money. It's very, very cost effective to run harm reduction programs. For a little less than $1 that you spend in harm reduction work, you save roughly $20. So when you start to add that up, it's big.
Yes, very much so. I want to ask the panel, because we only have about 5 minutes left, what would you encourage us as private citizens to do? Letters? Do we show up at council meetings? Do we go to the Board of Supervisors? What do we do? Do we volunteer on different places in the community? Any suggestions? Jill?
Well, I'm not the direct service person. I'm not the person that does a lot of the work that you all do. But I think that in general, the idea that engage people, form relationships, realize that, there are a lot of great resources and services and supports in our community. And we really all have to work together. I mean, that's why we have the coalition, so that we are working on harm reduction, prevention, treatment, recovery, and enforcement. So there's a whole realm of things that we're all part of in different ways. But it really does come down to not stigmatizing and engaging individuals and supporting them where they are.
Dr. Kyle Patton, any thoughts?
I mean, I think it's a big I think the fact that you're all here tonight, I think I think you should applaud yourselves for that. You don't have to really, it's fine. I think we need to change the narrative, right? Like, there are some outdated narratives that we deal with here in Shasta County, which does create barriers for our folks, not only from the standpoint of treatment, but also from a harm reduction standpoint, right? So in a lot of ways, the stigma that we as a community espouse, it's perpetuating this problem. It's creating real life barriers for people. And so just the fact that you're educating yourself, that you're here, you're coming from a place of trying to understand what people are going through, I think taking that out, spreading it in the community, taking it to the Board of Supervisors, taking it to the City Council, we need more help, we need more resources, and I think as soon as we as a community can say, like, we own this problem together, I think that's, then we can truly, like, move forward with this.
Yes. Susie Foster, family nurse practitioner, any thoughts?
I think Dr. Patton hit it on the head. I'm really impressed with the number of people that showed up tonight. I think it's about starting to have the conversation. I think that all of us probably have friends and family who have some of those outdated philosophies and information in their head. And It's not, while it's hard to have those conversations sometimes, it's not about avoiding the conversation. It's about addressing the stigma and addressing the misinformation head on.
Yes.
There's no other way to fight this other than to do that.
Yes. Raven, do you want to address this question and give your closing thought?
Yeah, sure. So first, to address the question, I believe the question is asking, can these harm reduction efforts prolong addiction, self-destruction, behavior enabling, question mark, question mark, question mark. No. For those of us who have or do use drugs, we are going to stop using drugs when we have determined that it's time for us and when our circumstances meet up with that. And it's a really special, particular moment that's difficult to come by. And in the time that we're waiting for their life, have transparent, healthy boundaries with me. We're not asking you to take on the things that we're going through, right? We are all on different paths. And whether or not we get harm reduction services in our life, I will tell you right now that if it was not for harm reduction, I probably wouldn't be here today. And I don't mean sitting in front of you, I mean alive. So
it works.
When you ask me if it prolongs it, no, it shortened it for me and it gave me life and it gave me a job and it never, ever, ever quit on me when everything else did. My closing remarks in regard to what do you do? There's a couple of different things. Yes, if you are somebody who is about politics and politically minded, please go to the Board of Supervisors, vote on things that we say are supportive to this work. Do your research before you check that box. Make sure it really is coming from the voice of the people who need the service. That is one thing. We live in a really small city. I know people in this room from living here 20 years ago. Okay? It is a small environment. And just like every other thing that we are trying to change in this world that isn't working, your job is to go home and fix it around your dinner table. Because we need more people. We need more people that care about us unconditionally. And I'm not saying again that you got to bring us home. I'm not saying that. And the other thing is, if this isn't your work, if it's not what you support, if you find people in your life that you're like, I just can't get them to turn the corner and understand this, then all I'm asking is get out of the way and do the thing that you're really good at and the thing that you're supposed to be doing on this planet. You heard the guy say that ran that site for so long. I knew that this is what I was supposed to be doing. But for people like me who have been living it and doing it for over 20 years, we're tired. That's why he left. But we can't stop because we're still dying, because we're still suffering, we're still getting arrested, we're still getting stigmatized. The place that it starts is for every single person. Yes, thank you for being here. And check your language, because how you speak on something is how you train your brain, is how you respond to it. So when you say those people, when you drive down the street tonight and point at the people who don't have a home to go home to tonight, and you think in your head for a moment, trying to see people, stop and say, hey, I see you, what's up? Right? Because we are all people, we just people different. So get curious about the people around you, because you don't know anything about the people even in this room. You don't know how many people in this room don't have a house. You don't know how many people in this room are doing drugs. You don't know how many people in this room are struggling with domestic violence. You don't know how many people in this room don't have any food at home, right? But I'm going to tell you, every single one of you is in this room. So we've got to get to a place where we're able to look at, I see myself in every single one of you, and my job is to get curious and say, who are you? Who are you different than you? And who are you different than you? And what do you need? And that is what we do in harm reduction, is we create families when we don't have them and truly listen to each other and be curious about who each other is.
Bravo. Don't you think? It's wonderful. Love that. Have a couple of things we want to have you remember. One, in the back of the room, and I think Renee is back there with this handout. Hill Country Clinic is asking you to participate in a survey. It's anonymous. You take the flyer home with you and help them gather information. So our panel, Jill Phillips, Dr. Kyle Patton, Sue, nurse practitioner, and Raven Hoops. I want to thank you. There's going to be a demonstration that Raven's going to lead on the Narcan demo. Are you going to do it back there or up here?
Wherever you want me.
We need to do it up there so we can do it on video.
That's right. I forgot. Yes.
I'd also just like to thank KIXE for bringing this film, for supporting this film, for being brave to show it and invite people to this table. It's super important to have folks like you standing up for this.
And remember, friends, February 13th, 10 p.m., Channel 9. It's also streamed after that. And if you can tune into the radio program to hear Colin and Raven talk about the film and the same issues we've been talking about, it's an hour interview, February 13th, Monday morning at 8 a.m. on 88.5 FM. I want to thank you all. Don't miss the demonstration here. Raven's going to help us out. Thank you.
Also, injectable naloxone, that's what you saw used on the film. Naloxone is the medication. Narcan is just the brand of this nasal spray. But you will hear me use the words interchangeably because Narcan has become like the word Band-Aid. Yes? Okay. So I do have injectable naloxone. Injectable naloxone is typically seen as something that works better and is better for the person who receives it than nasal. All of that to say, it does require having a needle to get it into their body. So if you are interested in being trained on and carrying injectable naloxone, you can grab one of my cards in the back or speak to me afterwards because I do a more specific training with you where you demonstrate that you know how to stick a needle in somebody. Okay? So for the purposes of this demonstration, we're going to speak about nasal naloxone. So the most important message that I can give you around overdose response, some blood pressure who's going to be presented with an overdose, you don't have an oxygen tank or a breathing bag or a meter to determine. So the number one thing before you put naloxone into somebody's body is to determine that they are unresponsive. Unresponsive means they can't respond. So if you come across someone who apparently looks unconscious and you say, "Hey, how's it going? You're looking kind of sleepy. Hey, are you all right?" And they go, that's a response. Okay? So the reason you see them using the meters is because they're being very specific of the moment that someone needs naloxone. You may not have that expertise or those tools. So before you give someone naloxone, which is going to send them into straight up withdrawals, which is very painful, you're going to take all of the opiate effect away from them. Before you make that decision for them, please do your best to determine that they are unresponsive. What's the most important word? That they're unresponsive, right? Now, when in doubt, please help them, okay? But do your best to determine that they're unresponsive. The way that we do that is we start by, if somebody looks as though they're not able to breathe on their own, one of the first things that's going to happen is that their lips are going to turn purple, their fingertips, their skin is going to eventually become sort of an ashen color. Opiate overdose is about lack of oxygen. We're not talking about CPR and restarting the heart. The heart often is still pumping when somebody's in an overdose. We're talking about not enough oxygen, okay? So we're talking about naloxone and breathing for people, okay? The only thing that naloxone does is stop an opiate overdose. Nothing else. It has no addictive qualities, and you cannot be harmed by this. I have taught as young as a 4-year-old to use nasal naloxone, and I've taught as young as a 6-year-old to use injectable. Okay? So nasal, the worst case scenario is they spray it in their eye, and then they need an eye flush. Okay? But this medication does one thing. It lifts opiate off the brain so the body can breathe. So this person might start with sort of a snoring, gurgling kind of sound as the muscles are relaxing. They're not getting enough oxygen. The weight of the opiate is stopping the message from the central nervous system that says breathe. So we've got to lift that off of that system. So this person, I'm going to start with verbal cues to determine if they are what? Unresponsive. That's right. Or responsive. Sure. Okay. Now, if you've ever stopped breathing, then you know that it's terrible on the way there and it's terrible on the way out. But while you're not breathing, it's quite euphoric. So every sound that this person is hearing is like a beautiful melody. The birds, the train, everything kind of becomes one. So if you approach the person and say, hey, how's it going? I was just wondering if you're okay. You're kind of going to sound like the rest of the melody. So we're going to be a little bit more aggressive, right? Don't put your hands on them yet. You don't know what the situation is. Hey, I was just walking by. Hey, my name's Raven. Are you all right? Hey, buddy, you just sleeping? Hey, if I'm not getting any response from this person, I've got to move into a little bit of physical discomfort, okay? So with my verbal cues, I'm trying to get the brain to go somewhere else from where it's tripping around and doing just like fine in its world, right? If that doesn't work, then I've got to get perhaps the brain to respond to pain. Oftentimes when we have pain, our body will just go into fight or flight and we'll wake up and we're ready and let's go. So people will teach you different ways. I'm pretty old school. So we teach the sternum rub. So if you take these knuckles and you run it down the rigid bone in the center of the chest, that's your sternum, you're going to apply some pressure. Remember, this person is not responding, right? So we're not going to be nice. Hey, wake up. We're going to be like, hey, buddy, come on. I don't want to have to Narcan you. Come on. You got this? Right? So I'm being loud. If I know their name, use their name, okay? And then you're going to move to some kind of physical pain, but you're not beating them up, right? So sternum rub, great way to do it. It's not working. I'm not getting a response. So I'm going to respond as if it's an overdose. Inside of a nasal box, you have 2 doses. They're a very simple nasal spray. You open it up. It works like any nasal spray. 2 fingers, thumb on the inside here on the plunger, and you're going to put it into their nostril until your fingers hit their nose, and you're going to compress the button all the way. Okay? Right before I do that, I'm going to do something called verbal Narcanning. That's just the nice thing to do because I'm about to wreck your day. Yes? So, I'm not getting a response from you. I'm sorry, brother. I've got to Narcan you. No response. Okay? Now, at this point, you have an option. This person's not getting enough oxygen. You can breathe for them. You can keep someone alive and without brain damage for some time, breathing for them. And brain damage will happen in as little as 3 minutes. So now I've given him 1 dose. This is 1 whole dose of naloxone. I've given him 1 dose. It can take up to 3 minutes for this to work. That's an awful long time. So what I'm going to do, hey buddy, did that work? Are you coming back? No? Okay. I'm going to tilt the chin. I'm going to check the mouth, make sure there's nothing in the mouth so I don't breathe it down into their airway. If there is, I'm going to finger sweep it out. If not, tilt the chin, pinch the nose so the air doesn't come out the nose, completely seal this person's mouth, and I'm going to give them 2 big breaths because I don't know how long it's been. And count to 5. You heard this in the movie. 1, 2, 3, 4, 5. Now I'm going to give them 1 breath. 1, 2, 3, 4, 5. Another breath. You're going to do that for the 2 to 3 minutes that it takes for that first dose of naloxone to kick in. Sometimes this is an estimate of time. If you've never been in a life-threatening situation like this, it will feel like a lifetime. Your body will be in fight or flight. You may lose track of time. If other people around, ask them to help you. If you don't get a response in 2 to 3 minutes, you can open the second one and spray it in their nose. Okay? Now, at any point in this process, if the person wakes up, hey, how's it going? Are you all right? They wake up. Hey, I was just wondering, could I help you get over onto your side? This is called the recovery position. Okay? So I'm going to see if I can get their permission to help them roll over on their side. This way, if they vomit, they don't asphyxiate. Yeah? So the recovery position is like a sideways Superman. Bottom arm out, bottom leg out. The top leg is going to be bent over the top. That'll shift their weight forward. And the top arm goes between the arm and the head to protect the face from hitting the ground. Okay? So if you have to walk away, they're in a safer situation if something does happen. So at any point, if they wake up when you yell at them, when you cause a little bit of pain, or after you've given the naloxone, or while you're breathing for them, at the point that they wake up, if they cannot sit up, you're going to ask if you could help them onto their side into the recovery position. Naloxone is a temporary medication that lasts anywhere from roughly 20 to 30 minutes to 90 minutes, maybe 2 hours. It lasts a shorter period of time than most of the opiates that are sitting on the brain. So when the opiates are attached to the brain, the Narcan comes in, splits it, attaches to the brain receptor, the opiate lifts. But eventually the Narcan is going to leave, and whatever's left of the impact of the opiate will rebind to the receptor. That can send somebody back into an overdose. So the other message for people is, hey, I'm going to hang out with you for a little while. I know that you feel sick, you're not feeling good, but even if you were to use drugs right now, you wouldn't feel them because that Narcan is there. And then you'd have too much again when the Narcan wears out. Immediately when somebody wakes up, let them know what happened. Hey, I know things are at. Please sit back after the paramedics are coming. And what sometimes can happen is you can have a lesser response from law enforcement, which can exasperate some of the other situations and make things more stressful and discourage people from calling 911 in the future. This is about getting people back to a living state from potentially losing their life. That is the number one issue of responding with Narcan or naloxone. The only difference between the nasal and the injectable, other than that you have to have a needle to inject it, is the actual nasal or injecting. Everything else remains the same. It's a muscle injection. It's not Pulp Fiction. We're not putting adrenaline shots into the heart. Although the heart is a muscle, that's not the one we're headed for. So that is the only difference, is just learning how to draw up the fluid and inject it into somebody. The response remains the same. Check to see if they respond to verbal cues. No. Check to see if they respond to physical cues. No. Verbally Narcan them. I'm about to give you some medicine that's going to make you feel bad. Sorry. Give them the medicine. If you are able to and willing to, breathe for them. Breathe for them for 2 to 3 minutes. And then if they still haven't come back, then give them the second dose. Questions? No questions.
Information overload.
Yeah, totally, yeah.
I've heard from someone that with the rise of fentanyl, they've had to use more Narcan for overdoses.
Yeah, great question. So yes and no. It's all of that and above. So when we first started getting the increase of fentanyl, because fentanyl has been in the drug supply and in the streets for several years, FYI, but when we started to get the increase in it, we did get more and more responses from people saying, well, I had to use 5 doses to wake them up. It is true that fentanyl will bind a little bit tougher to the receptor than heroin or other opiates. And so that can be a reason that someone might need more naloxone. But we're also starting to realize through data from the people who are experiencing this in their real life and time is that a couple of other things are also happening. So again, harm reduction is about realistic, real messaging. So one of the things can be that the fentanyl load is too heavy, but oftentimes what we're starting to realize is that there's also a heavy load, whether unknown or known, of benzos or tranquilizers and or alcohol. So all of your depressants on the central nervous system will increase your chance for an overdose. If something is laced with benzos and xylazine, which is a tranquilizer, and you're using an opiate, but it's laced with those, you've now stacked 3 depressants on your central nervous system. And the only thing that Narcan lifts is the opiate. So you could pump somebody full of Narcan all day long, but if there's so much weight on the brain in that way, you're never going to end up lifting the benzo, et cetera, et cetera. So we're finding that that is sometimes the reason. The other thing that's happening is that with public panic, we have people not waiting the 2 to 3 minutes. So what we're starting to learn is that people have gotten so urgent about the conversation of overdose that we're starting to panic and feel like we got to give them more naloxone, more naloxone. Please know the only person that gets hurt by naloxone is the person that you've just revived their life. They are in withdrawal for however long you stuck however much naloxone in them. It's very painful. So we want to be respectful and dignified with the individual and give them the littlest amount possible of naloxone to just bring them back out where they're able to breathe on their own again. And if you can't determine that, if you only have 2 of these or 1 of these, it's a great time to call 911 if they haven't come back to you, because it might be that there's something else going on, right? Great question. Yeah.
If somebody comes out of it, is it typical that they're like, how do they respond typically?
Yeah.
So are they going to be potentially like violent because they feel ill? Are they gonna feel so ill they like can't really move? Like,
sure.
What should you expect when you bring someone out?
Yeah, I would say expect all of it. So it can be any of those responses. I don't know that I would necessarily name a typical response. So people have, I think that we over amplify the idea that people come out swinging, right, but it can happen, right? So I'm not promising you that you won't get hit when you're down here breathing for somebody, because they have no idea what's going on and you're down here all up on their face, right? And this stops the opiate right now. So it's like thrusting people into that painful situation that they're trying to avoid, right? So yes, they can come out that way, but you also saw in the film a handful of people being revived from an overdose who sort of like, it's like a sit back up, a marginal sort of like, where am I? What's going on? Right? And then there's a lot of like, leave me alone. Like, but it's going to vary just depending. It's going to vary on how sick it makes them. Right? It's going to vary on what was the state that they were in before that happened. Who's around? Are there lights and sirens and then the police are standing over them? They might come out feeling really like, whoa, I was doing fine. What happened, right? So there's every response. People also commonly will vomit anytime that you're rescue breathing or bringing someone back. There's a possibility of vomit, right? So when I train people, I give out these marginal little CPR masks to try to encourage people to breathe for each other. But all of that to say, chances are, if you were breathing for someone and that happened, you would probably be okay. Now, it's not to say that there's not some risk in that, right? But that's another thing that can happen sometimes when people are coming out. If somebody comes out of an overdose and they're not able to just kind of hang, right? But they're talking real funny and they're complaining that things feel really stiff, or they are not able to stand up once they're feeling a little better, they may need more medical attention. They might have hit their head when they fell out. They may have had a seizure, a stroke, something that you're not aware of. So also encouraging people to get follow-up medical help if they're really unstable after the situation is important. But it's a dynamic response, Yeah, just like any drug, drugs work differently in each one of us. And our response to it looks a little bit different. But I would expect them to not feel good, whatever that looks like. Mm-hmm. Anybody else? Oh, I'm so sorry.
No, you're fine. Sources of Narcan that we can easier for us to say find than just calling police and no, I
How much do you want?
For others who don't.
Yeah, absolutely. Thank you for asking that question. So if anybody, Jill, I don't have your number up here. If anybody needs, there she is. If anybody needs Narcan, whether, I don't know, Jill, do you have injectable or am I the only one carrying that? Okay, so if you need Narcan, you can contact me directly. My card is in the back. The number on that card you can give to absolutely anyone in this community, okay? We also have several outreach workers in this community who carry Narcan and are also accessible as well. You can reach out to Shasta Mutual Aid locally. They have nasal Narcan and injectable Narcan that they can hand out. Jill Phillips, if you get in touch with Jill Phillips, I believe Jill's contact is also on the back. Jill runs the Shasta Opiate Coalition and almost always has Narcan. In fact, when I first got back to this town, everybody pointed me to Jill for Narcan. So myself, Jill, and I will go anywhere and train on this. So just last week, I was sitting at somebody's kitchen table with this very individual that you see here, teaching them how they might revive their adult child should that individual overdose. So I will meet you anywhere, and I will give you as much Narcan as you think that you need. And I don't care where that is. I'll meet you in your house. I'll meet you in the back alley. I'll meet you by the river, wherever it is. And then I think Dr. Patton spoke to this. This doesn't save lives on the shelf. It doesn't save lives at my office. And it doesn't save lives. I would love for every single community member to be walking around with Narcan, okay? But we have a multi-million-dollar shortage of Narcan in the state of California to put enough Narcan in people's hands to keep up with the rate of overdose. That's why we have injectable. It's much cheaper, okay? It's also more effective. There's a lot of good things about this. So it's great to give this to everybody, but if you get this from us, and you think that you're least likely, but you know someone else in your life that would be more likely to be present during an overdose, get it to them and then come back to me for more, okay? It's not a one and done. So you can take it today. After seeing this presentation, all I ask of you is to make sure that the person is unresponsive, because opiates will give people a really good nod that looks like unconsciousness. You saw it in the movie, right? And some people would panic and give naloxone to each one of those people, and they actually only gave it to about half of them, right? The rest of it was supporting, reminding them to breathe, keeping the vocal cues going. Can I touch your shoulder? Do you need to sit up, right? So remember that that's a very important piece to this. Some people will actually make agreements, like, let's say we use drugs together. I might be like, never use Narcan on me. And if we are close enough and we have an understanding, you probably won't. You probably won't. I might be like, you could breathe for me all day long, but never use Narcan on me. Or we might make an agreement, never call 911. You can do everything you can to try to save my life, but don't you ever call 911. And that might be because I work at the state capitol and I can't have people knowing that I was picked up on an overdose. And yes, I've done syringe service program for people that work at our state capitol. So it is important, they probably don't work there anymore. It is important, not because of the drugs, just because of how long ago it was. It is super important to try to really determine, is this person not responsive? Again, if in doubt and you're not getting enough from them, go ahead and it's not the right thing that they need. And that's why you want to make sure you call 911. But it's not going to hurt them any worse. Yeah, it's not going to hurt them any worse. Because you're in a hurry. So if I don't have a home behind a dumpster and I'm trying not to let you see me and catch me because I know you're bringing the trash out pretty soon, I'm going to not really have a super safe situation. One of the only harm reduction techniques that I can give to that person is, here's your Narcan. They're not going to use it on themselves, right? Because you use it when you're unconscious. When you go figure out where you're going to go sit down and post up and deal with, be in your state of mind, just set this outside next to you. At the very least. That way, if you're walking by and I'm out, there's Narcan right there, even if you don't have it. And sometimes that's the only thing that I can offer somebody who's in a situation where they don't have a safe place to be or they don't have anyone that they can rely on.
If we come across somebody who is doing very minimal responsiveness, how long would you wait next to them, or would you would you call on it, like not law enforcement but medical services, just in case you walked away and then they overdosed? Sure. Like what's the time frame?
Yeah, sure. So if somebody is apparently unconscious and you can't stay or you don't have Narcan, then calling 911 would be appropriate and say, I'm standing on the corner of Hartnell and Bocelli and someone's laying here and they're not responding to me and I got to go. They're going to get somebody there, okay? If this person can speak, please ask their permission before you call 911. Big mistake to make those decisions for people. Causes oftentimes much more harm for that person than it does good. Now, here's something to help you with that when it's not the extreme, right? When it's not like, I'm not getting a response and I don't have anything, so I'm going to call 911. That's one. Hey, are you okay? Hey, I can't stay with you. You want me to call 911? You want an ambulance? I don't want to. No. Okay, right? I am somebody who constantly is checking on people in my community who appear to be sleeping in a spot that maybe didn't look planned, right? But I also honor that sometimes it's the only place that you get to catch a nap. And I don't want to be the jerk that wakes you up, but I also don't want you to die. So let's say I'm going into the restaurant to have dinner with my family, and we pull into the parking lot, and this individual is kind of like splayed out, not quite looking like it's a nap, right? The first thing that I do is I go, I'll meet you inside. And then I walk over to the individual, and then I'm kind of a creeper. I kind of stand around the individual like this for a little bit and inspect, maybe not this close, and inspect to just see, is their chest rising and falling? Can I hear the breathing pattern? Does it sound like it's gurgly? Does it sound stressed? Does it sound regular? Do they look purple? And then if I see them like make a little, then I'm like, okay, they're probably sleeping. I go in, I have my dinner, I come back out, and I check on them before I leave the parking lot. That's about 30 minutes. If they slipped into an overdose, I'm ready to go. It's not perfect, but it's an opportunity to double check on them. No one is expecting you to come up on somebody and hang out for 2 hours, which is roughly what you would do. So in the movies, they teach you that you slam the drugs and then you're in an overdose. Yes, sometimes it's that quick, and sometimes you overdose an hour after you've used the drug. So you may not be able to stay there. If they're conscious enough, ask them if they want you to call 911. And then a lot of times, another thing I'll do, found somebody laid out under a bus stop on Hilltop. I pulled over. He was not well, but he was able to respond. And the woman that was with him was also nodding out. I got her to get conscious enough for me to say, can you stay awake to keep an eye on him? Because he's breathing right now, but he's not in great shape. I didn't have Narcan on me. I said, I'm going to run to my office really quick and get you some Narcan. Can you stay awake? And she was able to wake up enough with me that I felt good enough to race to my office and get Narcan. And I came back and then made her the responder should she need to be. Here's Narcan. Do you know how to use it? Keep an eye on this with him. See if you can keep him on his side, right? So those are ways that you can be supportive, is look around who's around them. Do they have community around them? Not always, but if they do, chances are those folks are going to be willing to keep an eye on them. Yeah. Thanks, everybody. There is Narcan in the back there. Jill is happy to have you walk away with nasal Narcan back there. There's also some informational flyers that I put back there if you're more curious about harm reduction, the history of it, and the tools that we use, the philosophies, and the ways that we approach things like substance use. I really appreciate all of you being here. And please take my card if you have anyone in your own life. If you're contemplating, questioning, how do I help people that I love? How do I create these healthy boundaries that Raven's ranting and raving about over here? Call me, let's talk. I care about this. I need my mask. There's too much coughing going on. I'm coughing because I need more water.